Okay.
Great.
Good morning and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We are just, whoops.
Sorry. There you go.
Okay. Um, we are discussing two bills this morning, which, I think will engender a little discussion on probably both of them. I'm going to ask all of those in the group. I wanted to sort of describe what I think is the process today. This is the place where we like to give people an opportunity to discuss, to potentially create options, questions. And then if we find ourselves in a place we can vote on a bill, we will do that. And so what I'm going to do is give as many people as I can a chance to discuss the bills. And but I'm going to ask that folks keep their comments concise, to the point. Please don't be repetitive. If someone has made your point, please, take your hand down. If you want to participate and make a statement, brief, concise, and to the point, please use your virtual hand, and I will follow the hands in the order that I see them. However, I will take subcommittee members in priority. So, with that, we are going to start with House Bill 424. Is Delegate White Holland on?
Yes, I am
Okay,
here.
great, thank you. 424 is Prescription Drug Affordability Board, Authority for Upper Payment Limits, Lowering Prescription Drug Costs for All Marylanders Now Act. This is a bill that had a very intense hearing on Thursday. Lisa, can you tell us what the bill does?
Sure. This bill repeals existing reporting requirements for the Prescription Drug Affordability Board regarding upper payment limits. Instead, the Prescription Drug Affordability Board must determine whether it is in the best interest of the state to expand its authority to set UPLs for purchases and payer reimbursements of prescription drug products in the state as specified in the bill. If PDAB makes this determination, it must establish a specified process and set upper payment limits in accordance with the process. The bill also authorizes PDAB to reconsider a UPL for a drug that becomes a current shortage, prohibits the board from taking action pertaining to certain UPLs, modifies the requirements and criteria for setting UPLs, and repeals obsolete language related to the Prescription Drug Affordability Fund. Also to note that the expansion of the UPL authority is contingent on two UPLs being established under current law, and for those to be in place for 1 year before any expansion of authority could happen. There are amendments that have been circulated, and those amendments require the board to confer with Medicaid before setting upper payment limits that may impact Medicaid. They provide that the authority to set upper payment limits does not apply to purchases and payer reimbursements related to certain federal programs. And it corrects a typo and makes the dates consistent for implementing the contingency.
Okay, thank you, Lisa. Delegate White Holland, would you like to say a few words before you rush to your next meeting?
Yes, thank you, Madam Chair, and good morning, colleagues. As I'm assigned to another subcommittee, I will need to depart early, so I do apologize that I'm not able to stay for the duration of this conversation. But I just simply want to emphasize that, again, that this bill will really afford our Prescription Drug Affordability Board to really have the tools that it needs to do what it's been charged to do. To date, they've done outstanding work. There's diverse representation across the prescription drug supply chain as part of the Stakeholder Council, and they have a thorough and transparent process for feedback. So waiting for more data, more reports, and further proof of concept is really not needed. I think that we have everything that we need, and we know a lot more now than we did back in 2019. And so we've also witnessed what has transpired in other states. We've tested out current mechanisms and processes, and we've learned a lot and understand what pitfalls to avoid. And so we have a lot to build upon, and I believe we have everything that we need now to move forward to expand the authority of the board to set upper payment limits for everyone. And so I just urge us to give the board every tool that they need to protect Marylanders and our healthcare system from high prescription drug costs. So I'll leave you with that, but thank you again, Madam Chair, for allowing me to share a few words. Thank you.
Thank you very much, Delegate. The only thing I would add to what the good delegate said was that we are giving the board, with this bill, we're giving the board the authority to set upper payment limits. But as we have heard a number of times in our presentations by the board, they are considering all options. So it's not that every drug that's considered will have an upper payment limit necessarily assigned to it. And the process for deciding that is iterative and includes at least 4 opportunities for public comment from the beginning of consideration until the end. And they are also looking at other options in ways to constrain costs. So with that, I would like to, if someone would move the amendments that were requested by the Maryland Health Department regarding
Move the
Medicaid.
amendments.
Second.
Thank you. Any discussion on the amendments? I think it's important in that second amendment that folks understand that these amendments will exclude any federally funded programs, drugs that are being delivered by federally funded programs. Any discussion on the amendments? Okay. Seeing no hands, those in favor of the amendments, please say aye and raise your hand. Okay. Any opposition to the amendments? Please raise your virtual hands. Okay, seeing none. So we now have the bill before us as amended. Before we begin discussion, can we have a motion on the bill as amended?
Second.
Okay, we have a motion and a second. I'll now open it for discussion on the bill as amended. If you have comments, questions, please raise your virtual hand. Delegate Kipke.
Thank you, Madam Chairman. I'll be brief because I know where this is going. But I feel as though I wouldn't be doing my job if I didn't briefly just say Maryland is ranked as one of the worst states in the nation for economic performance, 45th in the nation. And it's policies like this that I believe continue to weigh down Maryland's economy. There's no way to know if upper payment limits will actually provide savings for consumers. But we do know that policies like this have a negative impact on Maryland's economy. We compete with other states for economic activity, and this type of policy very much puts Maryland in a losing category as it relates to that. So I say that respectfully. I know the good intention. I love my vice chairman and some of the rest of you, but I just needed to put that out there, as I said in the hearing the other day. Thank you.
Thank you, Delegate, and I appreciate your insights and perspective. Delegate Morgan.
Thank you, Madam Chair. I want to echo some of the same sentiments that Delegate Kipke just said. And the governor came out last week in his State of the State speech and talked about economic growth in Maryland and us not having any. He's right. And it is policies like this are just erroneous on the economy that has this big economic stranglehold. The whole reason we created this back in 2019 as a pilot was to see how it would be implemented and if it was effective. This drug board hasn't lowered a single drug, period, in existence. And then you look at other states that have implemented this, like it was said in testimony, like Colorado, it's the same impact. They haven't lowered a single drug. So now we're expanding a board that hasn't really performed really well. And to me, that doesn't make any sense at all. This is the reason why we have a pilot project to make sure it is working before we expand it to the rest of the state. So, with all due respect, I wish we weren't passing the bill. So, but I'll hold my comments and be brief because, as Delegate Kipke said, we know where this is going. Thank you.
Thank you, Delegate. Aaliyah Horton.
Yes, hi, good, still good morning. I also recognize where this bill is going, but I also wouldn't be doing my job if I didn't repeat the concerns that our community has, and that this bill and the ability for the board to set upper payment limits really puts a ceiling on payments that the state pays, but provides no protections for how pharmacies are going to acquire the medications and how they'll be reimbursed. So they may be paying a much higher cost than what the upper payment limit is. And this is just another way that pharmacies will have under reimbursements and not be covered there. And my concern is that depending on how far this goes and which drugs, there could be an access issue if pharmacies choose not to stock the drug. So thank you.
So I see other two hands, but I'm going to ask Dr. Andrew York. Dr. York, you are on, right?
Yes, I am.
Can you address Aaliyah's concerns about the impact of potentially setting upper payment limits on pharmacists?
Yes, we are not exactly sure about how that concern would work. So I think, when we are looking at the work that we're doing, we generally look at the mission statement, and it includes protecting pharmacies from the high cost of prescription drugs. So ultimately, I think we would picture any upper payment limits to be set to be beneficial to pharmacies and help, serve the pharmacies. But happy to talk with any stakeholders on their concerns with how upper payment limits can be implemented.
Thank you. And Dr. York, will you confirm for me that if there is an upper payment limit set, that's the amount of money that the state of Maryland is going to, as the board stands now, the state of Maryland is going to pay. And so the negotiations with the pharmacists are going to be based on that number. But the bill says they can't suffer as a result of any decrease in the overall cost. Am I correct in that?
Right. So the way that the program works currently, that we're planning for it to work for state and local government, is to not change how the money flows through the supply chain, and to basically reconcile on the back end to get to a target net cost of the drug. And so if we were to expand to the full state, we would need to think through the different opportunities for implementation. I think there's a few different examples that exist out there. So for example, the Inflation Reduction Act has a process for if they are going to change the payment amount, that would also change the acquisition cost. So those are all things that I think we would want to explore as a board if we were to expand. But, as I mentioned, the current methodology for the state does not impact the supply chain payments and shouldn't have any impacts on pharmacies.
Thank you. Dominique Daniels.
Hi, everyone. I wanted to first thank you guys for your time and, the discussion and having this open discussion and having a patient perspective. As a patient, I feel like this is a dangerous game to kind of play because at the end of the day, our patients will suffer from this in some things that you can't just easily come back from. I don't think there has been any real results in this board. I don't think that when I testified the other day, there was no real savings to patients. There has been no way of how you really see the patient's savings. So I just want to make sure that you guys understand and see that as patients will suffer from this. We can talk about money all day, but you can't get back close people's lives when they don't have access to their medications that they need, when they aren't able to work. So like I get the overall outcome, but the bill hasn't actually done what it said it was going to do, which was save money for patients. And I thank you guys for your time. That's it for me.
Thank you, Ms. Daniels. I appreciate your being here. And I want to assure you that we hear you, but we have put some protections in the law that guard against accessibility of drugs. So, I hope I'm not sure that that gives you solace, but we do understand that concern. Lizzie Whittick.
Hi, good morning. Thank you for letting me speak. I'm from Tiger Lily Foundation. When I work with two of the patient advocates that came and spoke at the hearing last week, and asked me to come today on their behalf because of their work schedules, they weren't able to virtually. Tamika Johnson, excuse me, and Marquita Goodluck. And I would just like to thank again the state of Maryland for looking at possible solutions to this. We are 100% in support of reducing drug prices for patients. But again, as I just would like to echo what's been said multiple times, in all the states that have created PDABs and used UPLs, there have been zero cost savings for patients. The same in Maryland. And I understand the protections you guys have been talking about and looking at different modalities as well. But the fact remains that it has not been successful in saving patients any money. There are all these access concerns, which I know you're looking at. But this kind of experiment of looking and expanding a PDAB and using UPLs, any effect on a patient is going to be unacceptable. And Tamika, who testified last week, is living with metastatic breast cancer and has a really poignant way of talking about this. Anything that could delay treatments for her or access to them is really going to impact her ability to survive, be with her children, work, all these things, and experiment to figure out a way when you're experimenting on the patients that are living and having to use that access and need those treatments to survive, is not a good way to do that. And so we just ask that you all consider looking at other options before expanding this PDAB into using UPLs as a model that we already know doesn't work. And Marquita, who was the other patient who testified, had similar concerns. And also, I've heard some discussion today about feedback from patients and how that's working and representation on the board. But right now, there aren't any patient advocates or patient representatives on the board. And so that's a big concern for her as well, that those be brought up within the board, those viewpoints as these are being considered. So again, don't want to repeat everything that's been said, but both of our patients and our organization are very worried about this and hope that you would look at other options before passing this and expanding the current PDAB and using UPLs. Thank you.
Thank you. Dr. York, can you clarify for me, are there patient advocacy groups on the stakeholder group?
Each appointing officer has a general public member that has traditionally been a patient advocate or someone in the patient community, but there's not a specific delegated position that is explicitly for patients or patient advocates. I think we would certainly be interested in having patient advocates on the stakeholder council, and then also, we always try to work with the patient groups whenever possible. So,
okay, thank you. Amanda Boone.
Hello, thank you for having me today. My name is Amanda Boone, and I have cystic fibrosis, which I know you guys all know what happened here in Colorado. It was, I'm not going to go too into that because I think you guys know. But what I want to say is that the reason you saw such a public outcry is because the medication that I'm on, I literally was dying before I got this medication. I was actually being transplanted. I was being evaluated for a transplant. And I was on oxygen and I was living in and out of the hospital and I could not breathe. I could not take a deep breath. And I was able to escape that because of this drug, but I know many people that were not able to escape that life, and many people died and waiting for this drug. My family fundraised for this drug for years, lots of people in my community. I know that you guys have a skewed version of pharma, and it's like government against big pharma. And I get that, because I'm not saying that every pharmaceutical company does everything acting in good faith. But for rare disease drugs, it's just so different. We had to beg, borrow, and steal for someone to make a drug for us because we're such a small population. There's only 500 of us in Colorado. And that's where the access issue lied, because it's not enough leverage to keep a pharmaceutical company into that market. So unless you put that kind of rare carve out in your bill, and you actually, I understand when I heard you guys speaking last week, that you weren't going to do that to cystic fibrosis patients, but there's nothing saying they won't. And there's nothing limiting for, if let's say it's not CF, let's say it's Ehlers-Danlos syndrome, or another rare disease. There's nothing saying they won't do it. And the reason I'm fearful of that is because it's happened before. So the state of Arkansas did this in Medicaid years ago, prior to the modulator, before the gene therapy I'm on. I wasn't eligible for this one, but a part of our population was. People died. I'm not kidding. 2 years, these patients went without access, trying to fight the government. So they had to have a lawsuit, but it took them 2 years. So in that 2 years, this child died. And the Wall Street Journal, which is an odd place to do a pharma article, came down to Arkansas and did this huge press conference. And these patients had to literally sue the state of Arkansas to get their access back. They won. They won. The state of Arkansas wasted millions of, thousands of dollars in lawsuit fees, lawyers, cut off these patients, killed them. And in the end, these patients won. So I guess what I'm trying to say is, like, if you do something to where you do cut off access to a patient, you won't be looked at good. Not only will you not be looked at good, you won't feel good about what you're doing. And so I've done a lot of research on this and in other states as well, not just Colorado. And I like the idea, but it doesn't check the box. It doesn't work. And if you don't have a patient on the board, you're going to have problems on the board, not just the council. But thank you.
Well, just to be clear, the board is health economics experts. So they're folks who know the drug pricing sharing really well, just to be clear about who that
Ours
board
are
is.
too here in Colorado, but they did not know that cystic fibrosis, that Trifafta, they did not know that we had no other alternative therapy, even though we told them. But we do too. We have doctors, we have pharmacists, we have all of these people who are experts. That does not mean that they are an expert in my disease.
I appreciate that, Ms. Boone. Thank you. I'm going to go to Brandy Chain.
Hi, thank you. Brandy Chain with Pharmacists United for Truth and Transparency. I'll try to be quick here. I wanted to respond to something that Dr. York had said, and then echo Ms. Horton's points. So it sounds like you guys are moving forward. I would like to recommend maybe something to look at. I think as you look at these drugs, if you were to reach out and query independent pharmacies across the state and find out what their acquisition costs are for these drugs and implement something that protects them from losing money on these medications, and including an upper payment limit that includes a dispensing fee, because that's incredibly important to pharmacies. The only way that you protect patient access is by making sure that pharmacies are actually carrying those medications. So this is one way that you can do this. You cannot control what the wholesaler is going to sell those drugs to us for. So while it might sound like a great idea to talk about acquisition costs, you have no control over that. So it'd be really important to make sure that you know what pharmacies are purchasing these drugs for and make sure that they're protected. I will say that whenever it comes to the IRA, a large percentage of pharmacies responded to a survey about whether or not they would carry the medications that were in the IRA, and a large number of them said that they would not, because they cannot guarantee that they can purchase these drugs at these prices. Another thing would be if you were to add something in that would guarantee that the PBM would pass along the full amount of the UPL. That's another way that you could protect the pharmacies and protect the patient access. So what we've seen in the past, we just saw it this year. So while everyone is, upset about pharma and list prices and all this, we've seen multiple times where a manufacturer actually drops the list price of a drug, and then a PBM drops that drug from its formulary. So it's happened many times. So it's another thing to consider. If you set this UPL, there's no guarantee that this PBM is going to keep it on its formulary. So that's all I've got. Thank you.
Thank you. And I'm going to use a little executive privilege here to explain that we on the Health and Government Operations Committee and in the Maryland General Assembly understand and appreciate that pharmacists are generally the most challenged of all of the folks in the pricing chain. And we are committed to working on that. In fact, there was a bill on the floor this morning that's for greater regulation of pharmacy benefit managers that pharmacists have asked us for. And so that's an issue that we are absolutely working on. We are sympathetic to pharmacists, but it does not, as Dr. York said, there are contingencies in the whole model and process that are designed to watch out for pharmacists in the bill. So I'm going to go to Michael Eggings. I'm sorry. Thank you.
No, that was fine. And thank you for the opportunity to speak to you. I just wanted to build off of something that Amanda had spoken about as rare patients. I work with the Rare Access Action Project, and we represent advocates with rare diseases. And as you know, that is a disease that has technically under 200,000 in the US. But often we work with patients and patient groups where there's 200 or 300 or 1,200 nationwide. And so rare patients need to be looked at differently. And many rare patients travel out of states to centers of excellence for both their care and their therapies. In addition, rare therapies may often be provided by specialty pharmacies located out of state because of those small numbers that both Amanda and I are speaking about. So for example, if I'm a patient and I go to get my therapy doesn't go through a local pharmacy. I have to be contacted and connected with a specialty pharmacy that often will ship my product just on time. And those pharmacies are located outside of Maryland, beyond the purview of the PDAB. And for some rare patients, the costs assigned to their therapies includes not just the drug, but as you've heard from other folks who have testified, the services directly related to their care. And so that's a really very important thing to remember, is that you're not only paying for the price of or cost of the drug, but you're paying for the correlated care that is rolled into the cost of the drug. Since Maryland launched the first PDAB in 2019, it's important to remember that no PDAB has saved money either for patients or the states, not a dime. In fact, Oregon PDAB has put implementation on hold because of the challenges of both implementing a UPL and ensuring patient access. And so, as the other folks who have testified, we would love to work with you, not only on PDAB transparency, but better benefit design, smarter risk pooling, and other tools that have been shown that they can lower patient out-of-pocket costs. Because as recent studies have shown, if we can lower patient out-of-pocket costs, we have marked improvements in health outcomes. And so I wanted to share that with you from a rare patient perspective, because I think it's really important to understand that rare patients are not the same as other patients throughout the state. Thanks.
Thank you. Bridget Serrett.
Hello, and thank you for allowing me to comment today. I wanted to first echo Mike and Amanda's comments, because rare diseases, they are a completely different ball game and they have to be protected. And until you are 100% sure that access is not going to be compromised by this, perhaps maybe take rare diseases off the chopping block right now, off the negotiating block, because a UPL is not a cap on what I pay out of pocket. It's not a cap on what the manufacturer costs, or it's a cap on what my insurance can reimburse. And as we all know, there's this myth that formularies are chosen based on what is lower cost, and that is just not true. Formularies are actually chosen based on profit maximization, which means that my one drug that treats my disease, if they can't make the profit off of it, they're going to switch me to something else. And I can tell you with my specific case, there is no other drug that works. There may be 22 other drugs that treat my disease, but if I lose access to this, and this has actually happened where I've lost access. In 2016, I had a very bad series of unfortunate events, and I lost access to the one working medication that I have. I now need 10 reconstructive surgeries. I can no longer walk long distances. My spine is collapsing, and it's costing so much more than if I had had the 4 years of therapy. And this is something that you need to be very careful about, because just because there are alternative therapies doesn't mean that it's going to work. And insurance companies, the payers have been surveyed. They have said, and they're telling us they are not going to pass UPL savings on to the patient. What they're going to do is increase utilization management like fail first therapies, non medical switching, and all of these other tactics that they have, which is going to delay my treatment and exacerbate my disease in ways that are just absolutely horrific. Thank you.
Thank you. Thanks for coming this morning. Vinnie DeMarco.
Thank you, Madam Chair, members of the subcommittee. I appreciate this opportunity to chat with you one more time and for all you're doing to make healthcare more affordable for Marylanders. As you know so well, drugs don't work if people can't afford them. And this bill is before you because of patients like Erica Miller, who testified to you that she lost her job because her drugs were costing too much, and Larry Zarzecki, who lost his house and so much of his livelihood because these drugs were way too expensive. And we all suffer because our premiums are higher because 1/3 of the cost of insurance premiums is high cost drugs. And it is something that we all suffer from. And at the same time, as you saw from the Public Citizen report that's before you, the drug corporations in 2022, top 10 spent 20 billion more on profits and advertising, like those ads you saw on the Super Bowl, than on research. That's where they spend the money that could instead be making your high-cost drugs more affordable. And Madam Vice Chair, you brilliantly laid out how in nations like Germany, which have something like a prescription drug affordability board, they don't pay whatever it is that the drug corporations demand they pay. They pay a reasonable amount, and they pay a lot less than we do, a lot less, as you pointed out. And the drug corporations still sell the drugs there because they still make a lot of money. The fact of the matter is prescription drug affordability boards are a critical way to make high-cost drugs more affordable so people can afford the drugs they need without having to give up other necessities. Especially with the attacks by the Trump administration on the Inflation Reduction Act, we absolutely need our prescription drug affordability board to have the full authority to make high-cost drugs more affordable for all of us. You heard several people criticizing the board for not having done anything yet. Well, the fault there lies with Governor Larry Hogan, who vetoed their critical funding bill in 2020 and otherwise delayed appointments of the board so that they were delayed years beyond where we thought they were going to be acting. Luckily, Governor Westmore came in and quickly gave them the resources they need. So now we believe that in 2025, that board will make high-cost drugs more affordable for state and local governments, which will save all of us as taxpayers. But those who say, well, that doesn't help the average person, they miss the fact that we're all taxpayers, so we all benefit. But also, the patients will be helped by this bill. Your bill, Vice Chair Cullison, is what would allow this board to make high-cost drugs more affordable for everyone, which will help people at the drugstore counter afford their drugs. And as Acting Commissioner Marie Grant said so eloquently, they will require that the insurance companies pass on savings from upper payment limits to those of us who pay insurance premiums because at rate setting time. So the fact of the matter is that Maryland led the way with the Prescription Drug Affordability Board of 2019. And with this bill, you could finish the job so that we can now make high-cost drugs more affordable for all Marylanders. And thank you very much for your leadership.
Thank you, Vinny. I have 3 more hands. I'm going to just take these 3 more hands, and then I'm going to ask for the committee to consider where it would like to go next. Or actually, I will call for a vote on the. We already know it's already been moved and seconded, so I will call for a vote on the bill. So Kelly Schultz.
Hi, good afternoon, Madam Vice Chair. Kelly Schultz from the Maryland Tech Council. And I just want to start by saying sitting in your seats is always a very difficult task. And I am the first to say that the intent and everything that you are doing is all for the right reasons. But we do have to look at some of the unintended consequences that may be working against us on this particular issue. Everybody has been watching the news, and we understand that there is now, the New York Times called it this morning, an attack on pharmaceutical companies in the United States. I think it's titled Out to the Wood Chipper. And that is a dramatic hit to us, especially in Maryland, being the 3rd largest biotech center in the nation, right? But it's a fragile place in which we are in, because it's no longer that we would be competing for those types of very high-paying jobs that are going to, let's say, Boston or California. Now we really have to protect ourselves from areas like Ohio, where I know at least one of my members is opening a very large facility there. The economic realities are that in Maryland, we have over 400,000 tech workers, and they're being attacked at a lot of different angles across our state. And in order to be able to protect that, I think that we need to understand some of the economic realities of what we have. And we have to understand that even though we have wonderful assets, like was pointed out in the Senate hearing last week, that we do have wonderful assets in Maryland, like NIH and FDA, but that's not enough to be able to secure the jobs of the future and that workforce that we really owe something to, ways for them to be able to advance themselves, their families. There are very little occupations in this state that pay those types of entry-level wages for people in every demographic, those with high school diplomas. We're doing that. We're training them at BioHub Maryland. So I just wanted to not let that not be heard, because I believe that this ecosystem that we have spent many, many years to increase and improve. I was invited by Governor Moore 3 times in the last month and a half to come to his economic announcements, where he has stated that tech and life science are his main investment in growth for the state of Maryland. And this is completely opposite of being able to talk about what we can do to grow our health, our economy, and create those jobs for the future. So thank you very much, Madam Chair. I appreciate the opportunity to speak.
Thank you, Kelly. Darren Johnson.
Thank you, Madam Chairman. Darren Johnson on behalf of Amgen, but I want to speak as the industry's representative to the stakeholder council of the PDAB. And I think it's important because it also goes to several of the comments that the patient groups had made. And I've spoken to you, Madam Chairman, about this. I've spoken to other folks about this. The transparency I've heard of the board, I would take issue with some of the transparency of the board and the stakeholder council. I have raised over the last year or so the fact that all of our Zoom meetings are recorded, and now they are on, I guess, YouTube. But the board still has not put up from 2022, 2023, and the first maybe 1 or 2 of 2024, the recordings of the stakeholder council, so that advocates or anybody else can go back and look at and see what the decision-making process was. And if they can't do that, and then somebody will say also, well, you can look at the minutes. Well, the minutes are very, very high level. They don't give any detail. And so for advocates to go back and try to see what were the decisions that were made and how can we address those decisions, it is impossible. You go to the board. The board's meetings also have not been put up until last year. So, you go back to 2020, 21, 22, 23. None of them are available. That's not transparency. And that does not allow people to really understand the decision-making process. And then even with the decision-making process, I would say, and I give Dr. York a lot of credit, this is not the federal government, so they're not acting as like the Federal Register where there's an answer to every single question. I get that. But there's not a lot of answers back in general as to what might be right or what might that can be worked on later and things like that. It's always, well, we'll talk about it, at a later date. So that's really a concern. If you are going to now expand this authority more to have it in a much more complex system of really on the insurance side, not having that transparency, not having that dialogue, this is more dialogue than we're allowed to have at the stakeholder council meeting. Stakeholder council members are not allowed to ask questions of the people testifying. The board isn't allowed to ask questions either. And so what kind of back and forth, what kind of feedback is it when the public, the only feedback that's sort of allowed is their written comments, and then even then, there's no feedback. So I understand where this is going, Madam Chairman, but I do thank you for the opportunity to at least let yourself and the subcommittee know the process needs to be improved. And I don't know if there's something that needs to maybe be put in here a little bit to make it approved more or something, but it's just not working totally. So thank you.
Thank you, Darren. Those are good points. And I'll be talking with the board about how do we get this, because I'm committed to the process being as transparent as possible. And I appreciate your comments. Our last comment is Nathan Jabat.
Yeah, thank you, Madam Chair and members of the committee for giving me this chance to speak. So I heard comments that say that what PDAP is doing and what other place PDAP is not working, mentioning Colorado. What I wanted to say is that what is not working is the current model. What I mean by that is just when you get patients paying those in need, paying the majority and subsidizing the premiums of most people, that by itself works against the idea of insurance. So insurance was supposed to be where the majority of people pull in money to help the most needy, not the other way around. Not when the most needy, the patients that need the medication help reduce the premium. That's just not how it should work. And for those that say it doesn't work, the board and the bill is trying to make it work. And we know it works because we know how other countries' system we've seen work. So the delegate mentioned Germany. If we go and you see Germany's pharmaceutical pricing system, they've got one of the best systems and they've got the most low prices on orphan drugs. So that is given by, during the testimony, Skyrizi and Dupixent. You'll see that it is 500 and 450% less than what cost us here in the United States. So I heard from patient associations, rare disease associations that said, oh, we might not gain access. So access goes both ways, right? Access to medication and affordability is also access. So what is the point of the medication being there if you cannot pay for it? That still is an obstacle that the board is trying to overcome. So yeah, that is what I wanted to talk about. Thank you.
Thank you very much, Nathan. So I want to just address a couple of things that I heard, and the most being, we haven't seen the results yet. So why are we doing this now? Why are we trying to expand this authority? We are on the precipice of the first round of consideration of 2 drugs. Whether we may or may not end up with a UPL on either one of those drugs or both of those drugs. But we are now, the regulations and process are in place, which were built to be very rigorous. And so we've in the bill deliberately delayed the implementation of the extended authority for 1 year upon the implementation for the state and local government. And we did that. And so we're pushing this bill now because it will, if things work out the way that we think it will, and seeing the example that how other countries have done it, and that it will lower some cost for the state and local government insurance programs, we will be ready to hit the ground running. We won't have to wait 2 more years because that's what it will take for legislation to be implemented in a timely fashion. So that's why the bill is here now. And there are contingencies built in. If it doesn't work the way we anticipate, then we will not proceed with this authorization. We're trying to be responsible about it, but we also want it to be ready to go when we can. So with that, I am going to ask for a vote on the bill. So I'm going to ask, is the bill as amended? Those in favor of the bill as amended, please say aye and raise your hand.
Aye.
Okay. Those opposed to the bill as amended, I have Delegate Morgan, Delegate Kipke. Wait a minute. Okay, Delegate Morgan and Delegate Kipke. All right, I want to thank everyone for this conversation. I was I was glad that we had this time to listen to each other on this bill. I hope that the next bill will be a little bit quicker. And I don't know if Delegate Kerr is on, or is he in the waiting room? Because Delegate Kerr is the sponsor of the next bill. I don't see him, so we will try to represent him well. It's House Bill 297, and it's Maryland Health Benefit Exchange, state-based young adult health insurance subsidies pilot program sunset repeal. Lisa, what does the bill do?
This bill renames the state-based young adult subsidies pilot program to be the state-based young adult health insurance subsidies program and repeals the termination date. As introduced, the House and Senate cross files were not the same. So the amendments that have been distributed conform the House bill to Senate Bill 5. The differences between the two bills, the bill as amended will authorize rather than require the Maryland Health Benefit Exchange to establish and implement the program. And it prohibits the exchange from implementing the program if certain funds are not available.
Okay. No Delegate Kerr. So let me just quickly remind folks of what this bill does. So we set up the Young Adult Subsidies Program a few years ago, and it has been very successful. We've had like 100,000 young people between the ages of 18 and 34 get health insurance because we are able to, through state funds, subsidize their health insurance premiums. What the current bill, as it's written in the House, it mandates the program, which means that for $20 million would stay in that program going forward. What we're amending is to say, if there's funding available, then it will continue. And the reason we want young people in our healthcare, in our insurance pool, is they bring the cost of premiums down because they're healthier, they're paying in, and they're not using it. Hopefully, that's what we hope for. So with that, can I hear a motion on the amendments?
Move the amendments. Second.
Okay, that's been moved and seconded. Any discussion on the amendments? Seeing none, those in favor of the amendments, please say aye.
Aye.
Any opposition to the amendments? Seeing none, the amendments pass unanimously. Can I have a motion on the bill as amended?
Move as amended. Second bill as amended.
Okay. I've got a motion and a second to as on the bill as amended. Those any discussion on the bill as amended? Seeing none, I'll put it to a vote. Those in favor of the bill as amended, please say aye.
Aye. Aye.
Those opposed to the bill as amended, please raise your hands. Delegate Kipke and Morgan. Okay. All right. That bill was much simpler. Thank you all very much. The bill passes. Thank you again for your participation and attention to these important issues. We have a bill hearings beginning at 1 o'clock today. So we will see you there. Everyone stay safe and warm during the snowstorm. Thank you. Delegate Kipke, did you want to say something?